Imagine a medical complication, like so severe that tissue actually turns black and dies.
Oh, it is absolute nightmare fuel,
Right. And the groundbreaking rescue protocol to reverse it involves injecting Botox directly into the starving wound.
which sounds completely backwards when you first hear it.
It really does. Today, we're looking at the absolute frontier of aesthetic medicine, but we are looking way beyond the face. We're unpacking a massive shift in women's intimate health, specifically labia majora augmentation.
Yeah, and this is an area of medicine that has been, shrouded in silence for decades.
Oh, really?
For generations, women have just dealt with these structural and functional changes, kind of assuming it was an unavoidable penalty of aging or childbirth.
Great, just something you have to live with.
Exactly. But the science we're looking at today proves that is absolutely false.
So our mission in this deep dive is to synthesize a really compelling stack of clinical studies, anatomical mapping guides, and surgical protocols. We want to understand the actual science of revolumizing the external genitalia for you, the listener.
Because the transition from purely surgical excision to these minimally invasive regenerative techniques is fundamentally changing things.
We're going to explore the cellular mechanics of hyaluronic acid and autologous fat, how doctors are literally rebuilding tissue architecture, and ultimately we're going to break down that terrifying complication of a blocked blood vessel.
Right. We are moving from a paradigm of cutting away to a paradigm of restoring.
Okay, let's unpack this. To really grasp why this is such a breakthrough for you as a patient, we first have to understand the physical architecture of the area because it's incredibly complex.
It really is. You can't think of it as just a simple fold of skin.
Yeah, the sources describe the labia majora as the protective outer doors of the vulva. But when you look at the histological breakdown, it's like a highly engineered multi-layer system.
Functionally, you have a cutaneous surface, so a tough outer shield of squamous epithelium. But right beneath that is a dense vascular dermis, packed with sebaceous glands.
And those provide essential lubrication, right?
Exactly. And going even deeper, you find a specific fatty layer and then a specialized layer of smooth muscle fibers called the labial dartos.
The labial dartos.
Yeah, and that muscle layer is what gives the tissue its baseline tension and structural tone.
And just like the deeper fat pads in our cheeks, the fat pads and muscle tone in the labia majora don't stay static. The sources pinpoint menopause as a massive structural catalyst here.
Oh, absolutely. It's not just some vague aging process. It is a mechanical failure triggered by a drop in hormones.
Right.
That is the biological crux of the issue. Menopause causes a drastic drop in estrogen.
And that affects the fibroblasts, right?
Right. The fibroblasts, which are the cells that manufacture the structural scaffolding of your skin, they rely on estrogen receptors to tell them to keep producing collagen, elastin, and native hyaluronic acid.
So when those estrogen levels plummet, the signal just stops.
Exactly. The fibroblasts basically go dormant. Without that hormonal support, the area rapidly loses subcutaneous fat and collagen density. The tissue essentially deflates from the inside out, leading to severe sagging.
Which brings up a really fascinating clinical misconception highlighted in the studies. A lot of women go to a surgeon for a labiaplasty, assuming their inner lips, the labia minora, have suddenly grown.
Yeah, they think things have stretched out, and they ask the surgeon to cut them down.
But the anatomical mapping shows that often the inner lips haven't grown a single millimeter.
Not even a little bit. It is an optical illusion created by deflation. It is frequently a majora volume problem, not a minora excess problem.
Because the outer protective doors have lost their dense fatty volume and sagged, right?
Exactly. So the inner delicate structures are suddenly left exposed. In clinical terms, they are unveiled.
It makes me think of a vintage couch. If the inner cushion completely deflates and the fabric on top gets loose and wrinkly, your first instinct shouldn't be to take a pair of scissors and chop off the edges of the cushion cover.
Right, you don't cut the fabric.
You just restuff the cushion. You restore the volume so the fabric sits perfectly where it belongs.
That's a perfect analogy.
But reading through the functional assessments and the sources, this goes way beyond just wanting the couch to look pristine.
Oh, absolutely. What's fascinating here is that while the aesthetic element is certainly there, the functional impact of this deflation is profound.
Because they're protective.
Right, yes. The labia majora are evolutionarily designed to be a thick protective barrier for the highly sensitive internal structures.
So when you lose that volume, that barrier is severely compromised.
Exactly. The newly unveiled labia minora and the vaginal vestibule are suddenly subjected to constant daily friction against clothing.
I was reading the quality of life surveys, and it translates to everyday activities suddenly becoming like actively painful.
Riding a bicycle, horseback riding, wearing tight gym clothes.
Or even sexual intercourse becomes incredibly uncomfortable due to that constant mechanical friction and the chronic dryness.
Right. So by revolumizing the labia majora, you aren't just changing a visual contour, you are physically restoring a crucial protective anatomical barrier.
You are putting the shield back in place.
Precisely.
So if the core issue is structural deflation, the obvious question is, what do we use to reinflate it?
Right, the materials.
Medical engineering, detailed in the sources, primarily compares two completely different materials. Autologous fat, which is fat harvested from your own body, and highly specialized hyaluronic acid, or HA fillers.
Fat grafting has been the traditional gold standard for a while, honestly.
Okay.
The surgeon uses liposuction to harvest the fat, usually from the abdomen or inner thighs, processes it, and injects it into the labial tissue.
And the benefit there is longevity, right? Because the surviving fat cells become a permanent part of the tissue.
Exactly. However, it requires an actual surgical procedure, anesthesia, and the volumes required are surprisingly massive.
Yeah, the sources mention injecting anywhere from 18 to 120 milliliters per session.
That's a lot.
120 milliliters is basically half a cup of fat. That sounds like a tremendously traumatic volume for such a delicate space.
It is. It creates significant postoperative swelling and requires a real recovery period. That is why we are seeing a massive shift toward hyaluronic acid fillers.
Like Deserial or Novia Rose.
Yes, they offer a minimally invasive alternative that achieves similar structural support, but only requires injecting about 1.5 to 2 milliliters of HA gel per side.
Wow, that's a huge difference.
It's an outpatient procedure with virtually no downtime.
Now, I noticed a really specific, curious chemical detail regarding these HA fillers. Some of the formulations designed specifically for the vulva include an ingredient called mannitol.
Right, mannitol.
Now, mannitol is a type of sugar alcohol, and we usually see it used as a diuretic or an antioxidant. Adding an antioxidant into a thick, structural plumping gel seemed totally random to me at first.
It actually is a brilliant piece of biochemical engineering.
Really? How so?
Whenever a needle or cannula physically enters human tissue, that microtrauma causes immediate localized inflammation. Okay. And your immune system responds to that trauma by releasing a flood of free radicals. In a standard filler injection, those free radicals would immediately attack and begin breaking down the foreign hyaluronic acid gel you just meticulously placed.
So the body's defense mechanism actively destroys the expensive structural support you just paid for.
Precisely. But mannitol acts as a protective shield. It is a highly effective free radical scavenger.
Oh, I see.
It absorbs the oxidative stress caused by the injection trauma, which severely reduces the initial swelling and physically protects the HA polymer chains from being chewed up.
Which allows the gel to integrate smoothly and last significantly longer in the highly mobile tissue of the vulva, right? The
Yes.
sources say often up to a year or two.
Exactly.
That makes perfect sense. But getting that gel into the tissue isn't just a free-for-all plumping session.
Definitely not.
The surgical protocols detail a highly precise mapping system called the vulvar anatomical vector technique. They divide the tissue into specific zones, VA1 through VA5, mapping out the deep fat pads versus the superficial dermis.
And this is where precision is paramount, because labial dimensions vary wildly from person to person.
Yeah, this is where we really need to focus. The sources get deep into the actual physics of the procedure, specifically regarding how much filler a patient can safely handle.
Right, because the average physiological length is between 7 and 9.3 centimeters.
So if a practitioner blindly injects volume without respecting both the specific anatomical vector and the biological limits of the tissue, the results can be structurally disastrous.
This is a critical engineering principle for you to understand as a potential patient. You have to evaluate the integrity of the container before you fill it.
And this was the most fascinating biomechanical concept in the sources for me. The absolute maximum volume of filler that a labia majora pocket can structurally hold per session is directly determined by the patient's baseline skin elasticity.
What dermatologists call turgor.
Right, turgor. So how does baseline skin elasticity, or turgor, determine that maximum volume?
Well, baseline elasticity dictates how well the tissue can resist gravitational pull.
Oh.
So if a patient's labia are longer than 8 centimeters, or if their baseline turgor is severely compromised from extreme estrogen loss, that tissue pocket cannot physically support a heavy volume of gel.
Particularly in the lower anatomical vectors, right?
Yeah, exactly. The structural integrity of the pocket will just give out.
You can't put a heavy tile roof on a house with rotted wooden walls.
That is the perfect analogy. If a doctor ignores the turgor and injects the VA1 vector, which is the deep fat pad located at the very bottom of the labia, in a patient with poor elasticity, gravity immediately takes over.
Oh, wow.
The sheer physical weight of the HA gel will drag the compromised tissue down, exacerbating the sagging.
So you end up creating the exact opposite of the desired rejuvenating effect just because you exceeded the pocket's structural capacity.
Precisely. The biological elasticity dictates the absolute limit of the volume.
That is so important to grasp. And to avoid damaging that tissue even further during placement, they use an 18-gauge blunt cannula.
Right, instead of a sharp needle slicing blindly through the vascular network.
Yeah, they make one tiny entry point, slide this blunt, flexible tube beneath the skin, and lay the filler down in smooth, retrograde threads,
It gently pushes the vital blood vessels out of the way, rather than piercing them.
which drastically minimizes hematomas, bruising, and improves the overall safety profile of the injection.
Exactly.
So we've engineered the structure, we've respected the tissue's turgor, and we've safely placed the gel. But diving into the clinical trials, I wanted to know how we actually measure success for you, the patient, beyond just a subjective aesthetic improvement.
And the methodology here is incredibly rigorous.
Yeah, they don't just ask patients how they feel, they use advanced biometrics like the Dermalab suction probe.
The clinical data relies on quantifying the physical mechanics of the skin. The suction probe is a remarkable diagnostic tool.
How does it work exactly?
It places a small, controlled aperture against the vulvar skin and applies a very precise vacuum pressure to draw a tiny section of tissue up into the probe.
So it measures the physical resistance of the skin under stress.
Right. It measures the stress, the vacuum pressure applied, and the strain, which is how far the tissue actually stretches.
Okay.
But the most vital metric it calculates is what we call biological elasticity. This is the ratio of immediate recovery to total deformation.
In plain terms, when the vacuum turns off, how fast and how completely does the skin snap back to its original baseline?
Exactly. And looking at the data, after treatments using these specific HA fillers, particularly those cross-linked with PEG, or polyethylene glycol, the measurements for R0 improved radically.
And R0 represents absolute skin firmness, right?
Yes. And R5, which is net elasticity, also showed massive improvement. The skin didn't just look fuller, it mechanically behaved like younger, highly elastic tissue.
Which proves that hyaluronic acid is not just an inert, dumb space occupier like a silicone implant. It is highly bioactive.
It really is. The HA polymer draws in massive amounts of water, deeply rehydrating the extracellular matrix, but more importantly, the physical presence of the gel stretches the local fibroblasts.
This is that cellular trickery you see in mechanotransduction.
Exactly. When you put a fibroblast under mechanical tension, you stretch it, the cell senses that physical load.
So it interprets that tension as a signal that the structural scaffolding needs reinforcement.
Yes, which actively tricks the body into synthesizing fresh, native collagen and elastin.
And this structural regeneration translates directly to real-world functional results. The sources lean heavily on the Female Sexual Function Index, or FSFI, which is a standardized clinical questionnaire.
And the results there are striking.
Yeah. In randomized controlled trials, women treated with these fillers saw their FSFI scores improve significantly at the 6-month mark.
Because the restoration of that protective barrier physically changed their daily comfort and quality of life.
It represents a complete functional restoration, entirely validated by both mechanical biometrics and patient-reported outcomes.
Absolutely.
So we've spent a lot of time on the incredible benefits, but any deep dive into aesthetic medicine has to confront the darker realities.
Here's where it gets really interesting and a little scary.
Yeah. Anytime you are injecting a dense structural gel near a complex, highly variable vascular network like the anterior labial arteries, you are courting a severe risk.
The risk we are talking about is filler-induced vascular occlusion, or FIVO. It is universally considered the most dreaded complication in aesthetic medicine.
It is the ultimate nightmare scenario.
It really is.
If the tip of that cannula somehow compromises an artery and the practitioner pushes the plunger, the thick HA gel is injected directly into the bloodstream.
Or, if they misjudge the turgor and pack too much filler into a tight anatomical space, The sheer pressure of the gel can compress the artery from the outside.
Either way, the arterial blood supply to the tissue is instantaneously cut off.
The tissue is suddenly starving for oxygen. It is an acute ischemic event,
Mm.
and the biological clock starts ticking the second the blood flow stops.
The sources break down this vascular occlusion into 5 terrifying progressive stages of ischemia. Stage I happens almost immediately on the table, right?
Yes. The skin undergoes acute blanching. It turns stark, ghostly white because the arterial blood has literally been pushed out of the local capillary beds.
And if the practitioner misses that subtle color change and sends the patient home, it rapidly progresses to stage 2.
Stage 2 can persist for the first 48 hours, and it presents as something called livido reticularis.
Which is a highly distinct, mottled, purplish, net-like pattern on the skin. I was looking at the pathology of that, and the net-like pattern is actually caused by deoxygenated blood pooling in the venous plexuses.
Right, while the fresh arterial supply remains totally blocked. It's a literal map of the dying vessels.
That is so morbid, and if it isn't reversed by 72 hours, you hit stage 3.
At stage 3, the fundamental integrity of the skin barrier begins to break down. You see partial tissue desquamation.
So the superficial layers of the skin blister, peel, and slough off.
Exactly. And because the immune system relies on blood flow to deliver white blood cells, the area is completely defenseless.
So normal surface bacteria suddenly overgrow, plunging the starving tissue into a dangerous local infection.
Which accelerates the descent into stage 5, usually 5 to 10 days post-injection. This is coagulative necrosis,
The cellular structure collapses, the tissue literally dies, and begins to rot.
which culminates in the final irreversible phase, stage V, Escher formation. The skin turns into a hard, black, impenetrable scab of dead necrotic tissue.
It is a catastrophic biological cascade, and by the time a patient hits those later necrotic stages, traditional rescue protocols almost universally fail.
Yeah, which typically just involve injecting an enzyme to dissolve the filler. But by then, the vascular damage is too profound, and the tissue is already too far gone.
Which brings us to the absolute most gripping part of this clinical deep dive. The sources introduce a groundbreaking new case series that tackles this exact late-stage nightmare.
It's amazing.
They outline a multidisciplinary rescue protocol designed to reverse advanced ischemia, even in patients presenting at stages 3 to V. It's an acronym called THIS and FAT.
It represents a total paradigm shift in how we manage necrotic complications, moving from simple dissolution to aggressive regenerative medicine.
I really want to deconstruct this acronym because the very first letter, T, stopped me in my tracks. T stands for Botox, or botulinum toxin A.
Right.
We all know Botox is the gold standard for freezing facial muscles to stop forehead wrinkles. So reading that doctors are intentionally injecting a paralyzing neurotoxin directly into a starving necrotic wound felt totally contradictory.
On the surface, it sounds completely absurd. But when you look at the vascular physiology of an occlusion, it is actually a stroke of genius.
How so?
Well, when a main artery is suddenly blocked by filler, the body panics. The tissue goes into an acute phase of ischemia, and the surrounding collateral blood vessels, the secondary network known as choke vessels, go into a massive sympathetic fight-or-flight response.
Okay.
They spasm and clamp down tight in a desperate, misguided attempt to limit the damage.
So the body's own defense mechanism is actively choking off the only remaining backup blood supply.
Precisely. That vasospasm actively prevents any collateral blood flow from reaching the dying tissue.
And Botox fixes this.
Yes. Botox does not just paralyze skeletal muscle. Its deeper mechanism is that it actively blocks sympathetic nerve conduction to the smooth muscle lining the blood vessels.
Oh, wow. So by injecting Botox directly into the ischemic area, you chemically paralyze those spasming nerves.
Exactly. The choke vessels are physically forced to dilate and relax, opening the floodgates and allowing whatever collateral blood is available to rush back into the starving tissue.
Using a neurotoxin to force vasodilation is absolutely brilliant.
It really is.
Okay, so we forced the backup vessels open with the T. The H stands for hyaluronidase. This is the enzyme everyone knows is used to melt hyaluronic acid filler.
Right.
But the protocol stresses that you can't just inject it blindly and hope it finds the blockage.
Blind injection is totally useless in advanced necrosis. The THIS and the FAT protocol demands high-dose, pulsed injections, specifically 1,500 units every 20 minutes.
And crucially, it must be guided by high-frequency ultrasound, right?
Yes. The practitioner uses an ultrasound wand to visually locate the exact arterial blockage in real time.
So they inject the melting enzyme directly into the specific vascular pocket until they physically see the arterial blood flow return on the monitor.
Exactly. It's the difference between carpet bombing and a highly targeted sniper strike.
Okay, so we've dilated the collateral vessels, we've melted the physical blockage, now we get to the I and S. This stands for IPRF and SPRF.
Injectable and serum platelet-rich fibrin. This is where we cross fully into regenerative medicine.
They draw the patient's own blood and spin it in a centrifuge at very specific low-speed G-forces, right?
Right. This separates the red blood cells but preserves a dense, three-dimensional fibrin matrix,
And this matrix is absolutely packed with massive, concentrated doses of growth factors, specifically VEGF and PDGF.
which are the primary biological signals that stimulate angiogenesis, the rapid growth of new blood vessels.
So they inject this concentrated vascular fuel directly into the wound margins to rebuild the plumbing that the filler destroyed. Which brings us to the final, most aggressive part of the acronym, FAT. Specifically, nanofat and fat membranes, which are deployed for those horrific stage 4 and stage V cases where the skin has already turned black and died.
The preparation of nanofat is fascinating.
Yeah, they harvest a small amount of adipose tissue from the patient and mechanically emulsify it by pushing it rapidly back and forth through a series of increasingly tiny filters.
All the way down to 1.2 millimeters.
Wait, so they are essentially crushing the fat to a liquid?
Yes.
Yes.
They are purposefully destroying the large, bulky adipocytes, the mature fat cells, because they don't need the volume.
Okay, then what do they need?
By crushing the adipocytes, they isolate and preserve the stromal vascular fraction, which is incredibly rich in adipose-derived stem cells.
Oh, I see.
You are left with a liquid, stem cell-dense nanofat that is injected deep into the necrotic wound.
And for the worst cases of Escher, they actually suture a membrane of this fat directly over the dead tissue to force surface regeneration. I was absolutely floored by the statistical outcomes of this aggressive, multi-step rescue protocol. In the clinical case series detailed in our sources, dealing with patients who were referred days after their initial injections, already presenting with black necrotic tissue, 92% of the patients treated with a complete protocol recovered completely.
92%.
Their tissue regenerated without any permanent scarring.
To reverse coagulative necrosis and prevent permanent disfigurement in 92% of advanced late-stage cases is nothing short of a medical marvel.
It really is.
It definitively proves that tissue we previously wrote off as irrevocably dead can be coaxed back to life if you attack the pathology from every single biomechanical angle.
Neurological vasodilation, enzymatic dissolution, and stem cell regeneration.
Exactly.
It is an absolute masterclass in cellular manipulation. So to synthesize the journey we've taken today, for you listening, we started by exploring how menopause and the loss of estrogen receptors cause a structural collapse in the labia majora, compromising a vital anatomical barrier.
Right, the loss of that protective shield.
And then we explored the deep biophysics of augmentation, how a patient's baseline skin elasticity, or turgor, dictates the absolute physical limit of filler a pocket can hold per session.
Because if you exceed that turgor limit, gravity just drags the tissue down.
Exactly. And we learned how HA gels actually trick fibroblasts into regenerating the extracellular matrix.
We saw the rigorous mechanical proof of that regeneration through biometric suction probes.
And ultimately, we broke down the terrifying reality of vascular occlusion and the astonishing multidisciplinary science required to pull tissue back from the brink of necrosis.
It is the absolute bleeding edge of aesthetic medicine.
It really is. But looking at the mechanics of the this and fat protocol leaves us with a massive lingering question for you to chew on.
Yeah, this raises a huge point.
We are looking at a protocol that uses Botox-induced vasodilation, platelet-rich fibrin, and stem cell-dense nanofat to literally resurrect tissue that has turned black and necrotic from a blocked artery.
It proves we have the biological tools to reverse severe ischemic death.
Exactly. So what untapped potential do these exact same regenerative therapies hold for the rest of medicine?
Right.
Could we scale this protocol up to heal severe traumatic crush injuries, third-degree burns, or even chronic degenerative diseases that have absolutely nothing to do with cosmetic filler?
It's a profound thought.
If we can bring local tissue back from the brink of coagulative necrosis here, it completely redefines what we must accept as permanent tissue damage.